Thank you. So since time doesn't wait for no one, my name is David Musyoki. I work for Kehpca as a director for programs, and it's great that I'm moderating the session today. We have our panelists, and the first person or the first panelist to take us through the first session today is none other but Dr. Catherine Karekezi, who is a pharmacist, and she's been really a great pillar even in this process. She is from NCDAK, that is Non-Communicable Diseases of Kenya. Probably, Catherine, you could say hi.
Hi, everyone.
Great.
You can hear me?
Yes, we can. Second, we have Miss Benda Kehpca, great advocate. She, whenever you tell her to speak, she really speaks. Benda, you can say hi.
Hi, and thank you for inviting me.
Great, thank you. The third presenter will be Dr. Esther Mwinga, who is working with Kehpca as a coordinator for pain relief, and she's a great resource. Esther, you can say hi.
Hi, everyone. Hi. Bye.
We register the sounds behind the scenes. And lastly is Dr. Joy Frida, who has not slept for some time as she was working towards the success of this policy. Joy, you can say hi.
Hi, good evening, everyone. Thank you for joining us. My name is Joy Frida Chepchumba. I work with the National Cancer Control Program. I'm in charge of the Pillar 3, which is treatment, palliative care, and survivorship. And I'm glad to be here. I've been working closely with all these great personalities here. They've been of great use to my work at the program, and it's great to do this webinar with them. So thank you.
Thank you very much. So Howard is behind the scenes, ensuring that we run well, and I want to request him to project the slides, and I hand over the baton to Dr. Catherine to take us through the first session. Thank you very much.
Well, thank you very much, David. And good evening, everyone. I hope you can hear me. I'll be taking you through the introduction of the Kenya Palliative Care Policy 2021 to 2030. First slide, please. So essentially, this is chapter 1 of the policy, which is just an introduction to palliative care. Next slide, please. Starting first with an definitions, or at least so that we are all on the same page. Palliative care improves the quality of life of patients, both adults and children, and their families who are facing problems associated with life-threatening illnesses. It prevents and relieves suffering through the early identification, correct assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual. Next slide, please. Yes, just to remind everyone that palliative care commences from diagnosis up to end-of-life care and should be accessible throughout the continuum of care at all levels of the health service provision. This is despite the common understanding that palliative care just comes in at end of life. So essentially it commences from time of diagnosis throughout the care and should be available at all levels of health service provision. End-of-life care helps those with advanced, progressive, incurable illness to live well as much as possible until they die. It entails identifying and meeting the supportive and palliative care needs of both the patients and their families throughout the last phase of life and into bereavement. Next slide, please. Just a brief about the global and regional status of palliative care. Out of 56.2 million deaths recorded worldwide in 2015, about 45% of them, which is 2.5 million, experience serious health-related suffering. More than 80% of these 2.5 million who experienced the serious health-related suffering in 2015 were from developing regions, and the vast majority of them lacked access to palliative care and pain relief. Annually, about 2.5 million children die with serious health-related suffering, and more than 98% of these children are from developing regions. It is also estimated that in low-income countries, at least 93% of child deaths associated with serious health-related suffering are avoidable. And more than 80% of these patients live in low and middle-income countries where palliative care and pain relief is scarce or non-existent. 2,000 adults and children received palliative care services in 2019. I'd just like to look now at the WHO public health model approach. And this basically looks at the different challenges of palliative care development. Essentially, what are the main barriers to palliative care development? There's a lack of policy, limited education on palliative care amongst healthcare professionals. This is both for basic and specialist palliative care education. There's a lack of availability of palliative care medicines and also there are implementation challenges. In addition, of course, to psychosocial and other cultural factors that prohibit informing patients of their diagnosis and prognosis when the prognosis is life-threatening, and this also hinders palliative care development. So essentially, this public health model approach is focused firstly on policy, and here we're focusing on policymakers, regulators, WHO, and other NGOs. So here it's looking at palliative care as part of the National Health Plan, as part of the policies and related regulations, ensuring that there's funding for service delivery models to support palliative care delivery, and also essential medicines. So that is in regard to policy. In regard to education, where we're focusing on media and public advocacy, as well as curricula for training of healthcare professionals and other trainees, where we're looking at expert training. We're also looking at issues of capacity building or supporting the family caregiver training to support them as they support their family members. In terms of implementation, here we consider the community and clinical leaders and also administrators, focusing on opinion leaders, trainer manpower, strategic and business plans, including resources and infrastructure, and also the issue of standards and guidelines for implementation of palliative care. In terms of medicine availability, with a focus on pharmacists, drug regulators, and law enforcement agents. As we are well aware, opioids are essential medicines for palliative care. There's also the issue of the importation quota, the issue of costs, prescribing, distribution, dispensing, and administration. Next slide, please. In terms of the Kenya Constitution and policy commitments to palliative care, Kenya is a signatory to various treaties, declarations, and resolutions, and has essentially made commitments to palliative care. The World Health Assembly Resolution 67.19, which looks at strengthening of integration of palliative care services. The Global Action Plan for the Prevention and Control of Non-Communicable Diseases. This is from 2013 to 2020. And this looks at includes a development and implementation of a palliative care policy. Sustainable Development Goal number 3, with a focus on healthy lives and well-being. The Kenya Health Act of 2017, Vision 2030, the Kenya Health Policy 2014 to 2030, the National Cancer Control Strategy 2017 to 2022, and the National Cancer Policy 2019 to 2030, and of course, universal health coverage. So all these policies have a focus on palliative care, and the government has committed to develop palliative care in the country. Next slide, please. Situation analysis. This was a survey which was conducted between 2018 August and January 2019, with key informants including policymakers, healthcare providers, persons with palliative care needs, and training institutions. And this is just an analysis and showing the gaps which were identified from this survey. Firstly, palliative care is not adequately provided across the healthcare levels. There's lack of care for healthcare workers who are providing palliative care. There's inadequate access to palliative care services, inadequate care for caregivers of persons living with palliative care needs, lack of awareness in the community on the importance and need for palliative care. Next slide, please. The lack of dissemination of palliative care or palliative policies and guidelines to policymakers. There's inadequate capacity for healthcare workers to adequately provide palliative care services. And there's a lack of recognition of palliative care and carer progression by some professional regulatory bodies. And lastly, there's inadequate palliative care student placement while in training. Essentially, these are some of the policy gaps which were identified during this situation analysis survey. Moving forward now to the policy. The vision of the palliative care policy is a Kenyan population with access to quality palliative care services. And the mission is to ensure provision of timely, culturally appropriate, evidence-based, holistic palliative care services for the improvement of quality of life for persons living with palliative care needs. And the goal is to enhance palliative care services in Kenya by guaranteeing equitable access to quality services at every point of demand. I'd just like to thank you for your attention, and I'd hand over back to David.
Thank you very much, Dr. Karekezi, for that highlight. We move to the second point, which is now the pillars of the policy. And Benda is ready. Karibu.
Asante sana, David, and asante, Dr. Karekezi, for the preamble, which really sets the pace for which we're going to discuss the policy pillars. Just before we move from that slide, I'd like just to mention that advocacy, well, I'm an advocacy specialist in health advocacy and communications. And often when we speak about policy and the policy pillars, it's because we're looking at how can we utilize this document to ensure that we are either influencing or shaping dialogue that can build evidence on the areas that we are covering. In this case, we're talking about palliative care, on how we can engage together for development planning and also for policy debates, and also how we can influence our policymakers and other policy agencies to dedicate resources to ensure that there are mechanisms for implementation of the document. Next, please. And so when we look at the palliative care policy document, it's anchored on 7 pillars. And these pillars are actually modeled around the WHO Health Systems Strengthening Framework, which targets the 7 building blocks that have been dealt with in terms of the 7 pillars. And the overall goals of these 7 building blocks is usually improved health, responsiveness, social and financial risk protection, as well as improved efficiency. So when we look at the palliative care policy document that we're discussing today, the brief covers the 7 pillars that I've mentioned, the first one being advocacy and communication, to be able to provide an understanding and to make all stakeholders aware of the policy document on palliative care and what are the key issues. Leadership and governance, which ensures that we have strategic frameworks for governance that will ensure
proper coordination, oversight, and accountability. We have service delivery, yet another pillar against the WHO Health Systems Strengthening Framework, which looks at ensuring that there is holistic and culturally appropriate approaches to palliative care services. That is at all levels of the healthcare system. Next, please. We have availability and access to essential medicines and commodities. And here we're looking at how do we ensure access, we ensure coverage, we ensure quality, and we ensure safety, so that at least there is affordability and access of palliative care services, medicines, and commodities at all levels of care. Then human resource and education, yet another pillar, which looks at ensuring we have adequate, knowledgeable, and skilled, as well as motivated health workforce for provision of palliative care services. Next, please. Then we move to health systems, health information systems and research. And in a nutshell, this looks at providing timely, reliable, and accessible quality health services information so that we can inform decision-making with evidence-based, and also to be able to generate innovative solutions through research. But also in health systems strengthening, health information systems, it's also so that we're able to track milestones of where we are at, and we are able to feed back into the system on whether the policy document is working or not. And lastly, in the 7 pillars is the healthcare financing, to ensure that there is adequate resources, both financial as well as other fiscal resources that can facilitate successful implementation, monitoring and evaluation, as well as learning for sustainable provision of palliative care services. Next, please. Now, what you'll notice in this document is that it has provided all the 7 pillars in great depth, where challenges are covered, priority action areas are covered. For example, when we look at the issue of limited awareness on palliative care, which is a challenge because we have a lack of understanding on what palliative care is and what it is not, then the recommended priority action is to strengthen palliative care advocacy and information management initiatives among all relevant stakeholders, including the users of the palliative care services themselves. And so in each of these pillars, you will find that the challenges have been outlined, and we have the priority actions that have been outlined. I think, as Dr. Karekezi mentioned earlier, this document is available online, and therefore, recognizing the time that we have, I'll pick 1 or 2 of each of the pillars and be able to elaborate on it, so that then we give the challenge to all of us who are on this call to first scrutinize the document, secondly, to understand it, and to even dialogue about it, so that we create the necessary awareness. Next, please. In leadership and governance, some of the challenges identified include poorly defined structures for palliative care stakeholders engagement and coordination, as well as lack of appropriate governance structures for palliative care at both the national and county levels. There is the limited knowledge and support for palliative care initiatives among its decision makers, both at national and county level. And there is existing prohibitive laws that limit prescription and access to opioids for palliative care. And so looking at the priority actions is to be able to address these challenges with such suggested policy priority actions, such as advocating for prioritizing of palliative care resources by policymakers, developing regular updates and disseminating this at the national disseminating the national palliative care guidelines, the document that we're discussing right now, and also establishing mechanisms to mainstream palliative care within the health sector and beyond. Let's move to the next. Service delivery, the pillar number 3, which was to ensure access to holistic and culturally appropriate palliative care services at all levels of the healthcare system. Some of the challenges include lack of well-defined standardized packages for provision of holistic palliative care services, going all the way to the challenge of addressing awareness on patients' rights patients' rights and needs of people living with palliative care needs, as well as the population aging, isolation of elders and growing non-communicable disease burden among older persons. You will notice that palliative care services, products and medicines is open to all kinds of illnesses. It's not just about one or two disease area. So looking at the aging population is critical, that the service is also modeled to ensure inclusiveness. And so with the suggested priority actions includes integrating palliative care in all relevant chronic and emerging diseases care models, among others. Next, please. The availability and access to essential medicines and commodities, and I would add services as well. That looks at ensuring access and affordability of palliative care medicines and commodities at all levels of care. And in advocating for this, the challenges they have been outlined against issues relating to inclusiveness, issues relating to availability, issues relating to funding for procurement of these essential services and medicines and commodities, issues relating to negative attitudes that would affect the demand and supply, including prescription and dispensing of the use of opioids, as well as the limited capacity of professionals on use of essential care, palliative care medicines, equipment, and commodities. And we're looking at then the suggested priority actions include incorporating the medicines, equipment, and commodities in the Kenya Essential Medicines, Equipment, Commodities list. And this again goes back to the WHO framework for health system strengthening, where we should also look at modeling on what is globally acceptable to locally available so that our people are getting the right services at the right time. Of course, subsidizing pricing, including palliative care health services in the UHC and insurance benefits packages, as well as strengthening the supply chain management and reporting systems for opioids and pain medicines at all levels of care. Next, please. The fifth pillar, human resource and education. We all can agree that without the right human resource capacity and awareness of the human resource capacity in provision of palliative care as a holistic service at all the different levels of care, then there would be the risk of excluding some people or denying some people the essential services. And so ensuring that we have adequate workforce, adequate capacities for training for holistic services, adequate recognition, motivation, and adequate support for the palliative care suppliers and providers, as well as adequate structures to promote career growth and remuneration, will lead to a better team that is delivering the palliative care service more happily. And therefore that integration, that liaising with the relevant ministries, including the Ministry of Education for curricular development and rollout, that inclusion of building capacity of the existing workforce to recognize palliative care services, all this encompasses the empowering of human resource capacity and education for palliative care services. Next, please. The second last pillar, health information systems and research. Looking at the challenges and the priority actions, again, in a nutshell, it is addressing the need for consistent data collection, consistent data reporting, both at the hospice and at the palliative care level, research that informs decision-making, ability to monitor and evaluate the frameworks for palliative care services, as well as the use of that data to influence decision-making. And of course, we're looking at all these priority actions addressing those challenges. And last but not least, next slide. Last but not least, being the healthcare financing. And as we all can understand, palliative care services comes at the level of also other competing priorities for both governments, both county and national government, as well as various programs that are running. And therefore looking at that element of financing to ensure proper palliative care service provision, and that requires the palliative care planning financing at both national and county governments, and ensuring that there is adequate coverage of PC services, as well as continued budgetary allocation in the essential care package for palliative care. And when we look at healthcare financing, I had mentioned earlier, we're looking at that element of strengthening the financing model to ensure continued regular strengthening of the provision of services and commodities, and ensuring that there is seamless public-private partnership so that we can have palliative care services integrated within the healthcare system, within the NHIF, within private insurance, and also in the UHC care plans. And I think I will stop there, David, and hand it over back to you. As I close, my ask is to everyone who is on the call, let's talk about this. Let's disseminate so that we ensure more people are engaged with this document and find ways to ensure that it's integrated into our daily conversations in advocacy and work. Thank you.
Wow. Many thanks, Brenda, for taking us through the 7 key policy pillars. And just to identify or trying to put these pillars into perspective, last week or 2 weeks ago, we made a visit to one of the counties in the country, and as we just did a bit of tours to check around and support supervision. And we did a home visit. We went to this family where there is a patient in need of palliative care or a recipient of palliative care from low socioeconomic kind of state. Fortunately, her symptoms have been managed, but what was most touching was the kind of needs that family has, because there is a child who is epileptic. Unfortunately, the child was locked in, many issues. And looking at the policy pillars, if we would be able to implement these policy pillars, or else do the priority actions as stated in this policy, there would be many Kenyans out there who are suffering, who would really be helped. And therefore, as we get opportunities to advocate for implementation of this policy, we are right if we just implemented the 7 policy pillars. Fortunately, before we left, we were able to talk to the county administrators about that need. And that is just one need. They promised to, respond and at least put those kind of needy patients into, NHIF support, intervene and have the response teams from the hospital respond to the needs outlined. I was just putting this to perspective to agree with Brenda that we need to really talk about this and at the same time also bring into action this policy pillars so that they are not just another document, another beautiful document. Welcome to write in your questions or responses, and as well as any comments that you have on the Q&A. And while we do that, I want to usher in the third presenter, Dr. Esther Mwinga, to take us through the key policy considerations. Welcome, Dr. Mwinga.
Thank you, David. So we'll go through chapter 3, which highlights more aspects, building on to what Dr. Karekezi and Brenda have highlighted. Next slide. So the key policy considerations we are discussing specifically in this policy include number 1, end of life care, the issue of advanced directives, do not resuscitate, survivorship, then palliative care needs in special populations. And that also builds on to what David has mentioned about the family that we visited when we were in one of the counties. So we'll start with number 1, end of life care. And this, remember, for end of life care is not only specific to palliative care. End of life does affect all disease conditions. So remember, there's usually the beginning, then the tail end of it, when death is expected within a short time. That's what we refer to as end of life care. So palliative care is more than end of life care, and Dr. Karekezi mentioned that. Remember, we said it starts from diagnosis, but it's important to remember, even when we are caring for our patients, that the care we give must also focus on giving them a good send-off if they reach to this end of their trajectory. So it needs a multidisciplinary team approach and looking at holistic needs of the patient. So the physical needs, spiritual, and psychosocial needs, of course, with the family and caregivers as part of the caring team. So some of the challenges that we've seen in terms of having a good end of life care approach, especially for patients who are within a health facility. Number one, which cuts across many issues that have been mentioned this evening, is limited capacity of health workers. So in terms of their education, in terms of their confidence in dealing with end of life care. Then we also have limited guidelines that tackle end of life care. We also have the issue of legal and ethical dilemmas, and that's why we also work with legal practitioners, even as we look at the multidisciplinary team approach in palliative care, and then cultural and spiritual aspects that may come up. And remember, these vary depending on where your patient is. So the aspects, end of life care issues, for example, in Northeastern Kenya and those in maybe Nyanza would be different. Next slide. So in terms of priority, next slide. Priority actions that we would like to focus on, even as we implement this first policy, is looking at the issue of building capacity of healthcare providers and also the community health providers, because you remember patients, if we consider palliative care needs, patients living with palliative care needs may be in the hospital, in a building facility, but they may also be at home. So it's good for everyone to be confident enough to take care or give them a good setup wherever they are. Then establishment and implementation of guidelines, promote legislations that will be able to guide issues around end of life care. Then we need frameworks on ethical issues, and then being sensitive enough to address cultural and spiritual practices. Next slide. So the second special consideration that we are talking about is advanced directive, which really cuts across issue 1 and number 3 that we'll look at later. So advanced directives are usually given by the patient. So it means this patient has to be of sound mind when they're writing this. And this would be looking at giving direction. The patient says, in case I get to a point where I'm incapacitated, I would like you to do, as the healthcare provider, I would like you to implement X, Y, Z, or not do the other thing. So some will talk about their options for ICU care, their options for medication, their options for surgery. So these vary depending on the need of the patient. Next. In terms of challenges that we've highlighted when we are dealing with the advanced directives, they're similar to issues of end of life care. So we are looking at the ethical and legal challenges that affect advanced directives, healthcare professional challenges, reluctance of patients and families to have these discussions. And I know this is a taboo topic even across many disciplines, across many communities. And low knowledge and skills on importance of advanced directives, and that cuts across each and every person. And then sociocultural norms that affect decision-making process. So in terms of the priority actions that we are highlighting in this policy, next slide. We are looking at establishment and implementation of guidelines that would help give direction in terms of advanced directive issues. And this, I know there are some facilities that already have these things in place. And so that is, that changes facility by facility, but it's important to have these guidelines that can be adopted and implemented across our facilities. Then looking at the issue of capacity building, healthcare providers, so starting with ourselves so that we are also comfortable enough to start up these discussions, then empowering our patients and caregivers on advanced directives. Next slide. So we look at the third specific area, which is do not resuscitate. Maybe you may have heard of the word DNR, that is short form for this. And this is usually an order that is written by a clinician after you've had a discussion with the patient and the family, saying that when this happens, please do not resuscitate. And remember also, it has to be discussed before. And so we've had situations where families may come in and say, no, we want you to do the best. We want you to resuscitate this patient because in any case, we are the ones paying the bill. But remember, it's the patient who is at the center of this care. So if it needs to be documented clearly, and it needs to be said that this was done when the patient was okay and they were not coerced to do it. So sometimes the order may be requested on behalf of the patient's legal guardian. So legal issues really play a big role in terms of palliative care implementation. So that has to be documented that this was the patient's legal guardian in case the patient is not able to do this for themselves. In terms of challenges, next slide, ethical and legal dilemmas that face us each and every time. And I'm sure if I was to ask in this forum, many of you may have had these experiences on the ground. Then reluctance of medical personnel to issue DNR orders because we are taught to treat, we are taught to cure, so we think you want to do the best. But then again, the other end of the coin is it, are you doing more harm? Are you doing good for the patient? So that balance needs to be looked at. Are you looking at the four main pillars of ethical pillars? So you're looking at doing the best good for the patient. Then we also have inadequate information for patients to make this informed decision. And then delayed discussions on DNR limits, patient's participation. So if you start the discussion when the patient is at end of life, it's usually hard to even make an informed decision. So in terms of priority actions, there's need to establish and implement guidelines on DNR, and this can be facility-based. Remember, these issues will keep cropping up, and I mentioned that it's not only affecting persons living with palliative care need, but we know that this is where we mostly have these challenges coming up. Then building capacity of healthcare professionals to provide timely DNR support for those who need. Remember the patient as well as the family. So our fourth key aspect is survivorship. If we think of survivorship, we are looking at someone who has been diagnosed with a serious health-related condition. And the term survivorship, I know is a whole topic on its own. And for us, it's important for us to remember that this begins from the point of diagnosis. So there are different types of survivors, but what I'd like us to remember is that once you have this diagnosis with a life-threatening condition, survivorship begins there. There are 6 key areas of focus when you're thinking of survivorship: the social aspects, financial, psychological aspects, sexual, spiritual, and physical. Remember, these patients, even when going through treatment, for them, life still continues. So it's more than just the, for example, if it's a diagnosis of leukemia, it's more than just the treatment for leukemia. Are they working? Are they able to reintegrate back into their family? Are they facing stigma? Are they able to find meaningful employment or do work that will give them some financial support? So these are things that really need to come up from that point of diagnosis even as the patient continues with their therapies targeted at their condition. So challenges that have been highlighted in survivorship include lack of framework to guide survivorship care aspects, and then poorly coordinated MDT approaches. Remember, I've talked about we've talked about the 6 aspects of survivorship. If you're looking at the physical, the sexual needs, etc. So that is a multidisciplinary approach needs to be integrated or needs to be included as we are talking about that. Then limited research to guide implementation of survivorship programs and inadequate resources. So in terms of priority actions that we would like to focus on includes development of a survivorship care framework that looks at a holistic approach or takes a holistic approach, strengthening this health system so that we are ensuring provision of well-coordinated survivorship care. There are various aspects that different facilities, organizations, or healthcare providers are actually doing, but it's good to remember that the patient should be taken as not case XYZ, but person XYZ. So if it is Esther, you're looking at Esther's specific needs at that particular moment. Then, of course, the issue of research so that you see what ideal models would work for us. So this is a Kenyan palliative care policy. What would work for us as a Kenyan community? Then allocating adequate resources for implementation of survivorship programs. The last bit in terms of special considerations is palliative care needs in special populations. And we know this is key because palliative care does affect each and every one of us. So it's not just for adults. Remember, we are looking at children, we are looking at the needs of the older persons, asylum seekers, or we are looking at people who are refugees wherever they are, homeless individuals, persons in long-term care facilities. So when we are creating documents or creating guidelines that help in implementation of practices and care programs, it's important to note that these special groups may need different approaches just because of their specific titles that they have. So when you're looking at patients who have a psychiatric diagnosis, are we looking at their palliative care needs? If they have, for example, a diagnosis of cancer, they are admitted in a mental institution, are they able to get these services as they're getting their other therapies? For children, you are looking at when their medications, their approaches to care would be different than if you are looking at adults. Next slide. In terms of challenges, we are looking at issues of a lack of definition of a palliative care package for special needs populations. So what exactly do children need? What exactly will the older population need? What about patients who have different impairments, patients who are unable to walk, patients who are unable to hear? How are we communicating well? I know some counties are actually doing, what do you call it? Sign language training for their staff. Yeah. Then lack of integration of palliative care services in a special population, and then inadequacy of our healthcare professionals to provide the service. Next. So in terms of priority actions, and this list is not exhaustive. This is just what we are looking at would be a start, and then would be looking at building up on this. So allocating resources for palliative care package among special needs populations. We've talked about the special populations, the children, people with hearing challenges, people who are unable to move with ease, prisoners. Those are people that are key. And then integrating and institutionalizing provision of palliative care within the special population, and of course availing a trained workforce for the provision of holistic care. So these are things that we can look even from our institutional level. Are there things that we're able to implement even as we look forward to implementation of this policy at a county level, at a national level? I know some of these things we don't intend to forget them, but they need reminders so that we're able to prioritize and we're able to make sure that each and every person is reached where they are. Thank you very much.
Thank you, Dr. Mwinga, for that elaborate talk on the special considerations. And I see you've already responded to some of the concerns several people are raising on the chat. Probably for more interaction, we will have that session at the end. So now I want to welcome the last presenter, Dr. Joyfrida, to take us through the stakeholder mapping and stakeholder implementation matrix. I saw some few questions in terms of, so what happens? Who does what? Dr. Joyfrida, please.
Hi, good evening, everyone. Chapter 4 covers stakeholder mapping and implementation matrix. And as David has mentioned, generally it's all about who does what, who plays what role. So perhaps even the members on the group, you can see where you fit in this policy. So next. So the first people who are involved in the implementation is definitely the Ministry of Health, since this policy is hosted in the Ministry of Health, and it was developed by the Ministry of Health together with the partners. So the roles of the Ministry of Health in this case would be to disseminate this policy to the relevant departments, and this is why we're having this call. This is a second dissemination that we are having. Then they would go ahead to take lead in developing standards and guidelines. And in this case, the Ministry of Health will not work alone. It will just take the lead, but it needs to partner up with all the other relevant stakeholders. Also, it will provide technical and logistical support and capacity building for healthcare workers on palliative care, and also promote research. And we know when the Ministry of Health speaks on certain issues, it's actually more valuable than if it comes from any other avenue. So the Ministry of Health is taking a lead on this and just trying to really get people to know what palliative care is and how to make it better. Next, please. Next is the Ministry of Education. When the Ministry of Health is preparing its healthcare workers, these healthcare workers came from school. So the Ministry of Education, this is where it comes in. The palliative care needs to be included in the school curriculum, even in the, sometimes you have some in-service trainings, you need palliative care to be there. Also, we need more training institutions to be accredited that offer palliative care. And we've seen even some organizations that are not local, like I think Nairobi Hospice has a partnership with the Oxford University, and they offer a diploma, yes, in palliative care. So such partnerships in the education sector. And also in terms of research, I think maybe David mentioned we have a nurse who graduated in PhD in palliative care, which is a big milestone. So you can imagine the kind of research she had to do. And I believe she gained a lot of wealth of knowledge around this area. So we'd like to see more people going deep into this area. Next, please. The Ministry of Finance, as we can see, would like to see more resources allocated, for the implementation of this policy. We know we have so many people to reach in different populations. Maybe even the hospices are only maybe in urban areas, but we have people in rural areas, as David mentioned, where they're living in deplorable situations. And so we need to have more support from the Ministry of Finance, where they can allocate some resources for just palliative care services, because we have volunteers who don't wait in the hospitals only, or in the hospice. They go down to the communities, they go down to homes, and and try to provide the support to the people down there. Next, please. So we know the county governments are a big part of the administration. So we would really appreciate if the county governments would allocate the resources for provision of palliative care. And this can be in many forms. It can be in setting up more palliative care facilities. We currently, I think we have only 25 counties which have a palliative care facility. And we'd like to see around all of them, 47 counties, having at least one facility. In terms of capacity building, these facilities need, they need people to run it. So we need people from different cadres. It can even be just health volunteers. It can be medical officers. It can be nurses. It can be clinical officers. Just getting more people who can work in these facilities. Also, would like to see more multi-sectoral partnerships at county level. But we've seen palliative care being an area that needs just support from different areas. You find a partner coming in to help, even maybe in the building or in the furnishing of the facility or in training. So we'd like to see more partnerships. Also, and this is very important, implementing the policies and guidelines. We would not want to see this policy being shelved somewhere. We'd actually like to see it being implemented bit by bit. And my next slides will show what targets we have for the few years coming. And also would like to have some reports on palliative care. Just how are we doing? What commodities are available? Which ones are not available? How many people did we serve in the different counties, and so forth? Next, please. So the civil societies and generally we can see the three presenters who presented with me are part of the civil societies, in this case, their main work is advocacy. And I'd like to recognize Dr. Zipporah Ali. She was the CEO at Kehpca, and she was one of the pioneers of this policy, actually. And she really spearheaded the whole work around palliative care policy document. So you can see how important the civil society can be. So you can see Benda here is representing Kilele. Dr. Catherine is representing NCDAC, and we've really worked together with them in the cancer program to implement a lot of things. And they help us in advocacy, they help us to develop the documents and help us to just package the document in a way that it can speak to the common mwananchi, which is very essential. Also, I've already mentioned they participated in the policy formulation to promote awareness on palliative care. This they've been doing, and even now they're participating in this dissemination webinar. Also providing support for survivors and people living with palliative care needs. We have various organizations and the Kenya Network of Cancer Organizations. I think I can mention maybe Faraja, I think among others. They provide psychosocial support, and even I believe Kehpca has also that facility. So they really come in handy to support these patients. Next, please. The palliative care providers. So here we can see Kehpca leads in this as the Association of Hospices and Palliative Care Providers. And their role is to ensure provision and coordination of quality palliative care services. So we would like them to just have some uniform standard of care using such policy documents and maybe other accredited policies like maybe the WHO guidelines to ensure that they are providing quality palliative care. Also, we need them to influence skills and knowledge through e-learning platforms or on-job learning, mentorship, and research. I think Kehpca has already done some work around that, and even Nairobi Hospice, I know they're training something around palliative care. So you can see still the palliative care as part of their work. Apart from just providing the service, they also help in training. Also to liaison at all levels of care. We have a morphine reconstitution plant at Kenyatta, and Kehpca are heavily involved, and they coordinate morphine supply to all the levels of care in the country. So you can see how they're coming in handy. Also, just to support implementation of this policy to all the levels of care. Next, please. So next is the regulatory bodies. This is the Pharmacy and Poisons Board, the Kenya Medical Practitioners and Dentists Council, the Nursing Council, Clinical Officers Council. So the main role of these bodies is, first of all, to accredit palliative care and to define the structures, the organograms, to regulate and enforce, advocate also, to just add a voice that palliative care is a vital service that is needed in healthcare, and then provide direction on prescription and handling of opioids. We know we've had a challenge in this area. You can find a nurse is the only one available in a hospice, and they are not allowed to prescribe an opioid to these patients. And most of these patients are very, are in dire need of the opioids, they're in pain. So you can see we are using this policy to actually speak to the regulatory bodies that they could also allow these nurses who've been trained in palliative care and the experience that they can actually also prescribe the opioids. Next, we'll have the Kehpca. Kehpca is it's the body that the public body that stocks the commodities. So in this case, their role is to stock and supply essential palliative care medicines and commodities, including the oral morphine. Also, just to facilitate procurement, storage, and distribution, recommend other stakeholders to support procurement, and just identify and recommend digital technologies for the supply and distribution of palliative care commodities. Because you also don't want these commodities which are very sensitive, like morphine, just falling into the wrong hands or being unregulated. No, we'd like to see it came from Kehpca, it went to this facility, and it went to these patients, and we have the records at every step showing that. Next, please. So the training institutions. So here we have the universities, we have the KMTC, and also we've seen like now the international universities which are coming in to also partner with us. So their role is to institutionalize palliative care in all health training programs, to promote establishment of palliative care education and training programs, conduct research in palliative care, inform and guide policy review. So even in the development of this policy, we involved members of the training institutions so that we are able to enrich this document both ways, that the training institutions are aware that now there's new developments that they need to teach the students, and they're also, them as the training institutions, they're able to inform the ministry of maybe various additions that we need to put in the policy. So it's something that both parties actually collaborating. Also support community awareness creation on palliative care. We've seen some training institutions offering outreach programs, and that is good in terms of community awareness. Next, please. NHIF and other medical insurance. I think there could have even been a question around this. We are asking NHIF that palliative care is part of the medical needs of the patient. So it's not just the normal treatment or chemotherapy, maybe surgery and radiation. Even palliative care needs to be covered. And unfortunately, we've seen some hospices have not yet been accredited. And I think this is very, this is a gap that needs to be addressed, so that these patients, already by the time they're being hospitalized in the hospice, they've actually spent a lot of money in the treatment. So basically they don't have anything. They've done Harambes already. So if NHIF cannot cover them up to this point, it's pretty unfortunate. So we are actually asking NHIF and other private medical insurance to really provide comprehensive care to these patients, including palliative care. Next, please. So the next group of people is the public and persons living with palliative care needs. So their role in this case is the utilization of palliative care services, participate in policy formulation, implementation, and improvement. So if there's anything they would want to see improved, they need to find the channels to bring their views. I believe they can bring through Kehpca. They can also just come to the Ministry of Health. They can bring their views, and we can see how to improve things. Also to participate in palliative care awareness creation and communication within their communities. So in this case, maybe if the public sees there's a new cancer patient, as part of the care they are getting to palliative care. And once maybe a patient is aware of that, they're able to treatment become much better care providers. Next, please. Howard, can you hear me? Okay, thank you. The legal practitioners, their role is to provide legal guidance for healthcare workers, policymakers, and people living with palliative care needs on palliative care. Dr. Mwinga has highlighted all those legal issues around palliative care. Most people don't know. They don't know when to ask for a DNR, when to ask for advanced directives. They don't know when to bring in, a lawyer in all this. And I think it's important when they involve the palliative care specialist, they will actually be told of the various people that they need to work with to get all the support that they require. Next, please. The development partners, their role is to provide technical and financial resources for implementation of this policy. We understand this palliative care is an area that needs a lot of support, because as I mentioned before, the patient has already maybe exhausted their finances, maybe just trying to find other ways of getting better. So they need a place they can actually go and just get services without paying anything. Yes, and this is where the development partners can come to assist by setting up facilities that are free of charge, that have commodities in the facilities, and the patients can just get good palliative care services. Next, please. The media houses, their role is to create awareness on palliative care, advocate for quality reporting on palliative care, and dissemination of accurate palliative care information to create public awareness. As we know, people think palliative care is just something you come in when the patient has like 1 month to live or something, but that is not the information we are passing. We are saying, let the care be started right at the beginning. So let's try to pass the accurate information. Next, please. So what other additional support is required? I think Dr. Mwinga highlighted various areas that a patient will need support. So in terms of spiritual care, have you gotten in touch with maybe a priest for them, or an imam, or just someone? If they don't profess any of the faiths that you know, is there someone else that they relate to, that they can be called into to support them? Also, alternative medicine and herbalists and traditional healers. We know as part of, let's say, cancer treatment, because most of our palliative people living with palliative care needs are cancer patients. You'll find they'll try many options for cure and also just for pain relief. So we'd like some cohesion. We don't want the herbalist telling the patient, don't take the medicine that doctor gives you at the hospital, try this one. No, that's not what we are saying. We are saying if there are things that can alleviate, maybe the patient is not eating well, they'd like something to improve their appetite. That is something that can be taken in conjunction with the conventional medicine. So we'd like some cohesion, and if they're not sure, they can always check in with their doctor. We'd actually like to see both the traditional medicine specialist also consulting the conventional doctors, so that we don't have a collision in the treatment care. Next, please. So as part of monitoring and evaluation of this policy, we are going to do annual, midterm, and end-term reviews just to see how the policy is being disseminated and how is it being implemented. So the revision will be done depending on emerging national or patient needs or changes affecting provision of hospice and palliative care. Next, please. So what is our vision? The vision is to have the number of palliative care patients receiving these services to increase from 14,000, which was the estimate for 2021, to around 400,000. Because from our estimates, around 800,000 people need these palliative care services, but only 14,000 access these services. So we are hoping by 2030, 400,000 people will have received these services. The number of counties which have incorporated palliative care in their strategic plan, so far we've noted only 5 counties, and we are hoping by 2030, all the 47 counties will have palliative care in their strategic plan. In terms of palliative care personnel, the 2021 estimates are at 250, and we are hoping by 2030 we'll have around 5,000 personnel. The nurses trained to prescribe opioids, currently it's around 100 nurses, and this is for a big population of palliative, of people living with palliative care needs. So we are hoping by 2030, around 1,000 nurses would be trained to prescribe opioids. In terms of training, the number of co-curricula with palliative care, we've noted only 7. And we are hoping by 2030, at least 14 co-curriculars will have palliative care. Next, I think in conclusion, this is the last slide. So what are we saying? We're saying that palliative care approach can be offered by any cadre of healthcare worker, community healthcare worker, and community health volunteer at all levels of care. So we need to train everyone, train the medical officer, train the clinical officer, train the nurse, train the CHUs, train the CHVs on palliative care and what they can offer at that level. Of course, the CHV will not start prescribing opioids, yes, but there is some support that they can give these patients. So just there is appropriate training for each level. Everyone needs to be trained. In this training, palliative care facilities must be in every county. Budgetary allocation must be done to palliative care, NHIF to cover palliative care. Legal awareness is very necessary, and public awareness on palliative care. So I think that's all. So thank you. Back to you, David.
Wow, thank you. Thank you very much for outlining the different stakeholders and the expectations. We have about 10 minutes and would like to utilize the 10 minutes to have a bit of interaction. I've seen several questions come through, and so allow me just to go directly to the 3 questions on the Q&A, and I saw some few on the chat. We'll be able to get them. Dr. Wata is saying, thanks for the excellent presentation. Great to see my lecturer on farm chem, Dr. Karekezi. And I saw some chats in some place saying she was a strict lecturer. Good job, Dr. Karekezi. So does the policy address coverage of palliative care medicine and other commodities by NHIF? The cost of meds such as morphine tablet, SRN, fentanyl patch is very high considering they have to be used on long-term basis for many patients. And as she prepares to answer that, and I think also Dr. Mwinga can chip in, there is the question from Eunice. Why is government taking too long to start comprehensive palliative care centers as they did with HIV patients? So we can have those two. And then Dr. Joy Frida can answer or respond to Dr. Jonathan's question about bioethics committees and the multidisciplinary aspect in terms of answering ethical dilemmas, which he acknowledges can be very challenging. Yeah.
Okay, thank you, David, and thank you for the question, Dr. Wata. Yeah, obviously, there has been discussion with NHIF in regard to coverage of palliative care. I know even as NCD Alliance, we have had 1 or 2 discussions. It seems to be a long process, but at least we have started that discussion. And we hope that as we continue with the discussions, they'll actually understand the need to cover palliative care as under NHIF. In terms of the cost of the medicines, I think maybe Dr. Mwinga is best placed since she's the one who's actively involved in the pain relief. Dr. Esther?
Okay, thanks, Dr. Karekezi. I agree with what you have said. And in terms of looking at coverage for medicines, including pain relief, It's still work in progress, but what I know is that the policy is advocating for not just NHIF, but looking at medical insurances, having that covered so that a patient has holistic access to care as and when they need it. So that is a key consideration, Dr. Wata. Thank you. As well as the other non-farms, because there are other things that come that are not really medications and the patients would need that. The cost of the tablets and the fentanyl patches, I know there was, I think, discussion about quantities and costs coming down, but I'm happy that for the morphine solution that's available across all the counties, the cost has really been subsidized by all stakeholders who are involved in the access to oral morphine solution initiative. Thank you.
Thank you, Dr. Muhinga. There was the second bit concerning setting up of comprehensive palliative care centers. Or probably I could jump in. We've since 2010, with advocacy from Kehpca and other stakeholders, we've been working closely with the Ministry of Health to have integration of palliative care as part of comprehensive support that hospitals do. And like you saw highlighted in one of the presentations, palliative care needs to be like part of the services that every hospital provides up to sub-county level, with proper environment, with proper personnel in terms of healthcare providers, well trained, and as well as well equipped with essential palliative care medicines and other essentials. So that's why we're having this policy, and we're talking about now implementation of a policy to cover that. So yes, the response has been a bit slow, and we need many things in terms of resources, in terms of personnel, and the 7 key policy pillars, if addressed, then the response would be much faster. There was the third question from about issues around ethics and all that. Dr. Karekezi or Dr. Muhinga?
David, please repeat the question. Ethics.
Let me see. From Dr. Ndusi says the policies are great, and the policy is great and timely. Ethical dilemmas can be challenging, especially when patients and their families or health providers differ on their views regarding treatment options and the interpretation of advanced directives. It may be helpful to designate bioethics committees with a multidisciplinary composition who can be consulted whenever such dilemmas arise.
I think it's a comment, and it also builds to the Beatrice asked, how do I address pediatric ethical dilemmas and care decisions? So just adding to that is that the facilities, it would be good to have, as correctly put, bioethics committees that would help in terms of making decisions that are difficult to make as an individual. I know some facilities do have ethics committees that meet and discuss various issues that cut across disease conditions. For example, the issues of you have a child and the parents are refusing blood transfusion, and it's life-saving. How do you make a decision and how do you document it? So that is something we can also implement within our facilities. Thank you.
Thank you very much. From the chat, we majority of what is written there are comments. Somebody, Pranab from India, says unique webinar, informative presentation, and analyzing in lucid way. Somebody said, I've learned educative information, keeping abreast. That's nice. Bibiliana says, great presentation and the policy is well elaborated. But as a nutritionist from experience, the nutrition component to the palliative care patients always are considered last, only when the patient's nutrition status is severely compromised. I hope the policy has clearly brought out this component. Probably as we do that, Dr. Joy Frida, you could respond to the nutrition aspect as I read two other probably comments, and then we will be bringing it to a close in the interest of time. Somebody, Eunice, says somebody should do follow-up on NHIF to ensure they provide comprehensive care. I think that has been mentioned. Zippy says, well done team for the presentation. Let us always put the human face in whatever we do. True. Beatrice says, how do I address pediatric ethical dilemmas and care decisions? Again, a team approach and having the ethics and a team that would be looking at that and that decisions being made from a multidisciplinary team aspect. Very informative presentation. Well done to our presenters from Caroline. Yeah, basically those. So if we could respond to the nutrition aspects and the ethical dilemmas we already talked about. Yes, Dr. Jeffrey.
Okay, thank you, David. So it's true that the nutritionist needs to be involved also as part of the palliative care team. So that has been highlighted in the policy. So we would like to see the patient getting that support from the onset, as we're also giving them support in terms of psychological, spiritual, emotional, even financial. We also need to give them the nutritional support, which comes in through the nutritionist. So yeah, that's a very vital role that they play.
If I can add, go ahead, Brenda.
Sorry about that. I was going to say, and especially, sorry, when it comes to the multidisciplinary teams, I think when we look at the holistic approach to multidisciplinary care, it's about also including the voice of the patient or patient representatives on the panels that we form. I've seen, for example, in the ASCO setting, where we are called upon to represent the patient's voice by patient advocacy groups or patient advocates themselves, being invited to give their voice into the conversation. What happens is then everybody's thoughts and everybody's needs are taken into account, and also the same team that is representing the patient's voice can also go back to the community and create an understanding of what is required of the patients themselves. And when I speak here patient, I'm talking about caregivers as well as the patients themselves, so that we create a mutual understanding of what is necessary, from nutrition to care to even the end of life conversations that need to happen. Secondly, I've seen a question from one of the participants relating to the UHC. And the question is, how does this link in with the coverage of costs and aspirations for the UHC in Kenya? And I think in my presentation earlier, I did cover that this policy is anchored on the 7 pillars, and one of the pillars is healthcare financing, where we're looking at integration into both NHIF, the National Hospital Insurance Coverage, but also as well as in the UHC framework, so that the services, medicines, as well as the commodities for palliative care are integrated into the UHC framework. Thanks.
Thanks, Benda. I was going to add for nutrition. Remember, the needs of the patient vary from the time of diagnosis to end of life care, and their needs are different at each point of the disease. So it's important to work with the team, and the policy does talk about multidisciplinary approach. And I agree with you, Bibiana, that nutrition is key in terms of patient care and management, especially for patients with palliative care needs. So there was a patient yesterday who was telling me that the daughter has a diagnosis of cancer, and she said a nurse told them that they need to stop taking. She had a long list of things that she was told not to take. So my message is those conversations need to be brought to the table, even as the patient is talking to a healthcare worker. You have a right to ask questions. Why is this being stopped? Why am I being told not to eat this? But the general consensus is moderation in terms of food intake and IV fluid therapy, depending on the needs of the patient. So the multidisciplinary team approach needs to be enshrined and documented even as we take care of our patients. Thank you.
Okay, thank you very much. And in the interest of time, this brings us to the end of the session. Sorry, there is another moderator in the making. Don't be disrupted. So thank you very much. We appreciate your time. We appreciate your support, your audience. It's been awesome that we sat in. Thank you all presenters for your intelligence and sharing a lot of knowledge, responding to the questions, and at least being able to share this information about the policy. If you allow me, I was checking our bosses, if they are still around, but I'm sure they will not mind since we already are late. So if I'll just bring us to the end and we say a good night and a bye-bye, and we'll be sharing more information in case somebody needed to get this presentation. We recorded and it will be available. Again, the policy is downloadable, and we'll be carrying a series of these dissemination sessions some physically and others virtually. So let's keep being informed and mobilize as many people to listen in when those opportunities present. So thanks, Dr. Karekezi. Thanks, Ms. Benda. Thanks, Dr. Muinga, Dr. Joy Frida, and NCCP, and everybody that has made this a success. God bless you and good night. Bye.
Bye. Thank you and bye.
Bye. Thank you.